what drives the decrease and the increase. It was not really, what we have seen is an inverse. We have seen the decrease in the uptake of termination of pregnancy, and then we have seen an increase in deliveries. We have surpassed the 1 million deliveries per annum, which was lower while the termination of pregnancy was higher. We were around 800,000 deliveries. So we also working very closely with the NGOs and all other partners, and we're looking at outreach services and trying to make sure that everyone else gets on board onto this. Next slide, please. I think it's one, but last slide. So this is an example of an initiative that we've come to say some of the services really that we're providing after the initial assessment and eligibility and contact with the healthcare provider. Follow-up will really be the dispensing through the ATM. I think somebody mentioned it to say we really need to look at the sanitary towels. So this type of a vending machine, it's available in different areas. We're piloting it to expand the access, where is some of the follow-up, the PrEP, the PEP, the condoms, the oral contraceptives, and the sanitary towels can be dispensed through this. And then these machines are available. They've been placed in various different strategic areas. We're trying to improve the access. Next slide, please. Yes, I'm not going to go into details into this. This is just to say the roadmap of saying somebody's asking, where is this happening? Why don't we know about it? So I'm going to go into detailed pilot project. We just started it. So we have, this is just summarizing the milestones of where do we want to be. We're focusing on the TVETs. We are in KZN, Northern Cape, and Mpumalanga and Eastern Cape. For now, we're going to try it and then document the lessons learned, and then we'll review. So maybe next year, this time, we'll come back to this Caucus team to say this is these are the challenges or these are the successes of the model of digital self-care services for sexual and reproductive health. Next slide, please. So what are, the benefits really are vast, and then they've been documented. We're not trying something that has not been documented. We acknowledge that it's being documented. It reduces unnecessary clinical visits. It expands to the community that are the community members that are marginalized. It reduces the out-of-pocket expenditure. While we're saying our services are free, but we know there's an inherent out-of-pocket expenditure. It manages all that, and then it also provides an opportunity for remote access, dealing with issues around stigma and attitudes and all that. And then also it also saves times, both for the clinicians and for the users. Next slide, please. I think it should be the last one. Yes, but over and above that, I think the issues around, yes, I think this slide was added also because there was a request for the health to give us more information about the integrated school health program. Based on the time, I won't go much into that because really and truly, the package is vast and we target different learners, but we also acknowledge the fact that sometimes we identify them, but a follow through, it's a responsibility that has been allocated to parents or caregivers or whoever else that is managing the kids at home, but we still need to work on how do we follow through and make sure that the caregivers take them to the referred sites and then they report back and then they follow through for the subsequent management and so that it improves the outcomes, because we also know that the higher the educated the young girls, the better their management of the sexual and reproductive rights and needs. So the issues of vaccination, HPV vaccination, I also touched on it. We can move to the next slide. Yes, I spoke to this already to say while we've provided, we've expanded the method mix, we're still struggling with the skewness of the uptake. So really, this is where we call all the other members from different constituencies to say contraceptives is not all about DMPA, it's not about NET, and we've got a different new methods that we've introduced. Some of them, they've got more benefits because they're long-term. So we're really calling for the support of others to say, can we also support all this? And I know that there was an issue of social media. We've tried to do that through social media also to popularize some of the methods so that we don't all get stuck with the injectables, but we're still struggling with that. That is the area of improvement and recommendation that we would need from different multi-party organizations. Thank you. Yes, I think I've touched on this. Let me save time. We said we've moved for medical TOP, and then we're reducing the surgical TOP. And then I've also touched on this. We've done a lot in terms of where I spoke about the continuum. It's mainly to say we've now 8 visits. We're looking at nutrition because it's contributing to the death, the maternal death, the issues around education in terms of early warning signs, when to ask for help. Because I think what we are struggling with now is issues around the stillbirths. The number of stillbirths are very alarming. I think we're one of the highest countries with a high number of stillbirths, because mothers lose the babies. They're not aware that it actually takes a very short space of time for a child to suffocate in utero, and you actually lose. So the reduction in the mobility of the child is one of the education factors that we're emphasizing. I think also we have introduced the Mom Connect, which is also 9 years old now, and then it's been working. It creates an link between the clinical caregiver and women, and supports them through the process of pregnancy up until the end. And then we also struggling with the issues around maternal disrespectful care. So we've embarked on the actual roadshow in terms of responding to the respectful maternity care, so that maternal services is not a trauma to women, and is not actually exacerbating the issues of gender-based violence, but actually they receive a respectful maternity care. And the postnatally, we're also looking at making sure that the 6 days of delivery, that's where we know that the high incidence of postpartum depression happens. So we're strengthening the visits, and we're looking at breastfeeding, supporting breastfeeding, because supporting breastfeeding also assists in reducing the incidence of postpartum depression, but also provide contraceptives that we reduce untimed and unplanned subsequent pregnancies while you still have the small kid. Chair, I think I'm going to stop here, because the rest, it's things that I've covered, is just going into details in based on what is in all those guidelines. And those are some of the things that I spoke to even before we got to the presentation itself, because this one in the cervical cancer is mainly talking about what the guideline is talking about, and then the frequencies and the duration and the care and all that. So Chair, allow me to stop there, as I promised that I'll be done by exactly 10 to 1, so that I allow the 10 minutes to engage with honorable members. Thank you.
Thank you very much. Thank you very much for the presentation. Honorable members, we can now start engaging the presentation. Those who feels that they can write the question and send it to the secretariat, they can do so. Then the secretariat will send the response by writing also, and send it to the secretariat, and they distribute to the members. Thank you very much, honorable members. I see 3 hands. Mantuli, and then Miss Honorable Masiko Jele, and then Honorable Drucken. Mantuli, you can start.
Thank you, Chairperson. Chair, I will start by welcoming the presentation, but I must be honest and upfront, Chairperson. This is a very crucial presentation on women and health, but due to time constraints, the presenter was too fast. And again, you've opened that members can also jot down their questions. But you see, those questions are are not like interacting with the presenter. But nevertheless, Chair, let me ask some few questions. Chairperson and the meeting, in terms of cancer, the cancer was a sketch in our country way before HIV/AIDS, but cancer remains a serious killer. Now, I want to share from the department as to how they view their awareness to the communities in this regard, and the working relations with sectors, and also to check if they do have awareness at schools, at workplace, etc. Because with cancer, it's as if when AIDS landed in our country, we turned a blind ayanyana of some sort at cancer, and we, of course, the HIV and AIDS was killing people as well, but to me there is not a notch of saying it's as if we are not doing enough for cancer. Our public government hospitals and oncology centers, etc. So how is the department viewing that? Are they doing well? In terms of maternal mortality, Chair, the stats were very high that were shown by State South Africa, particularly with youth, etc. Now, I wanted to check if they are trying to dig down the root causes. For instance, the prenatal visits that are victims in this regard. Are the visits logical? And again, you go to other clinics and you find that particularly in the rural areas, you find that people wake up at 3 o'clock to catch the transport to the clinic, but when they got there, the clinic has got its own system of controlling, I don't know why, giving people numbers. Now, let me make an example of saying the last number is 50. If you get there after 50, obvious you are not going to be attended on that day. That means you must go back. Now, you've spent some money coming to the clinic, so it's not easy for you to come back tomorrow. So looking at all those things, if they are not the cause to say they then become lazy for the prenatal visit, of which will be very helpful to them for some of the problems to be identified. But then, Chair, going to HIV and AIDS, I think that one, Chair, on youth is still a serious problem in terms of poverty and and the sugar daddy's impact, etc. Now, what are they having okay, she mentioned the integrated programs. What are these programs bearing any fruit with the their programs, their integrated programs with Department of Education? Are these programs bearing fruit so far? Because the stakes were very high, meaning you see, you can have one sugar daddy infecting more than 10 children, because if you are poor and that sugar daddy is sort of dispensing money, giving out money, so children are being blinded in that regard. Thank you, Chair. But I must say that was it's one of the very crucial presentation on women and health, and really we applaud and we commend the department to come and present to us. But the time constraints was really a factor here. Thank
Chair,
you. I'm done. I'm done.
I think Chair is, I think he was kicked out.
Okay, let me respond to that while we're waiting for the chair to come back. I think the issues that were raised, we acknowledge them, and we know that we can't
Honorable
solve.
Maseko Jele.
Oh, Chair, okay. So my apology, Chair. She was already responding. I don't know if maybe we leave her to respond and finish, or maybe we'll just. Must I continue?
Can I give time to the two of you? Then she will respond yes to all the questions.
Okay, I think I will be very short, Chair. I think.
Honorable Maseko. Yes,
Yes.
please.
Yes, I'm talking. Hello, can you hear me?
Proceed.
Okay. No, thank
yes,
you very
ma,
much.
proceed.
Thank you very much, Chair, and also thank you very much for this informative presentation. I think we will get another chance also, yes, next time when they come back to indulge more on it. But I want to carry just to piggyback on the last sentence of Omamuntuli, where she was talking about the sugar daddy who is moving around impregnating little ones. I'm worried about that issue of, I don't know if maybe the guidelines are also addressing that issue of the children who are getting pregnant in the families, the incest, and also the issue of rape. And that issue of the sugar daddies, are the guidelines maybe covering also that part of before? Because if maybe we only concentrate on as to how we're going to eradicate maybe this and assist in terms of the pregnant, in the middle of the pregnant and all those things, but not concentrating what is the cause of that also. I think if we can also emphasize more, I was going to say, because your presentation was talking about policies, guidelines and policies. I wanted to find out also, is some of the things in these guidelines binding? Because by now, common sense tells me that if a child, if we can't be reading the stats of saying we have this number of children from 10 years to 16 years being pregnant without people being arrested. Here we're supposed to be given maybe a stats that tells us that these children, as these children are pregnant, because that's statutory rape. We can't, it's either a parent is arrested or the doer is arrested. So we need to get that report when we get such reports of how many, the stats of the little ones getting pregnant. Those children, they are supposed to be under the care of the parents. And if the parent suspects anything wrong, they must report it, whether it's your husband or your uncle. And even the mothers in those families, you can't also leave girl children with boys' children. Some of them, they sleep together in one blanket on the floor. You are not separating them. So those issues must be in the guidelines, and also they must be a punishment, a binding a punishment in terms of eradicating such behaviors. So lastly, Chair, it is on the only one question. I want to find out, because it was earlier indicated by Mamuntul about this AIDS coming to us, even COVID coming to us. We want to know, is this burden of the funds only carried by the country, South Africa only, or do we have money from the world, is it WHO or what, where they are assisting us to push these programs, such good programs that you have, like Abom Patla? Because where I am, I was thinking that we can't carry this alone unless it is a strategy of killing a Black child, or a strategy of indeed making sure that we are out of power. Because I don't think that the country will only concentrate on saving life without out of the means that they never costed, and which came outside. Even the companies, I think I wanted to say in short, in closure, the responsibilities of these big pharmaceutical companies. Because sometimes we would say, like, for example, we were told that there were those allegations that this COVID was man-made. So if these things are man-made, who is assisting us? Because now our money that is supposed to go to service delivery, it has to go to saving lives. And this side, the communities don't get what they're supposed to get, because chunk of the money goes in prevention of these things. I want to find out exactly what is the role or the assistance that we get from these pharmaceutical big companies that are benefiting out of these medications. Thank you. Thank you, Chair.
Thank you so much, Honorable Drucken.
Thank you very much. Thank you very much, Chairperson, and thank you for the presentation from the Department of Health. This presentation is very, very important, and it is a pity that we had to rush through it. And I agree with my other colleagues to say that maybe we can have a more detailed presentation from the department on cancer and what funding is allocated to cancer treatment. I think a couple of years ago, we listened to a presentation where it spoke about cancer, and they said that there's not enough funding that goes towards cancer treatment or cancer prevention. So just curious from the department how much funding is allocated to cancer. Maybe not now, but maybe in a next presentation that's more detailed, we can focus on that. Then also, I'd like to also let you know, I'm trying to have cancer presentations for the deaf community, because some clinics and hospitals presentations don't have access to people who are deaf on cancer issues. And one very interesting thing, I invited Cancer South Africa and another person, and I had to pay for them to come and do a presentation. So I'm just curious whether, for the testing of cancer, I'm just sure if, I just wanted to know if the Department of Health have free testings during Cancer Awareness Month. And I'm trying to make it a central point where all deaf people can come, where there's a sign language interpreter at the testing center on a specific day, where they can all get tested and screened, etc. So if the department has something like that we can look at. Then I'd also like to know, where's the project on the ABC project, because we hear a lot that the youth today are affected with HIV and AIDS, but previously we used to have, maybe 10 years ago, projects, the project Condomize the ABC, and now where is that program currently to teach today's youth 10, 20 years later, because the numbers of youth affected with HIV is increasing. So where is that message currently at? Then I'm worried that I'm still reading in the newspaper with regard to the attitude of the clinics, nurses' attitude to children who come to the clinics, who want to talk about family planning, what to do when they want to get an abortion, what to do to prevent, nurses asking them, why are they coming here? What are they doing here? So there's still a very negative attitude in there. So I'm just curious, how do you prevent that, and how can you encourage girls to go to clinics to get assistance, whatever the attitude may be, because they want privacy and confidentiality, but the message and their name gets spread around the community, and girls need help. But this issue of the attitude, I still read about it continuously, and it also causes you always get alarm causes of children who are pregnant in schools. Like Honorable Jele said, there's no punishment. Sometimes the educators impregnate the girls, and they pay the parents to keep quiet. So what do we do about those kind of things? So many of these things, the numbers are increasing. There's a lot of pregnancies. So what is really being done, and what can we as MPs assist with to help with this? Because it's a continuous thing. People are dying as well because of that, because people don't understand it necessarily. So what more can be done in terms of education? Then social workers at the schools or social workers from the department, do they go and check why there are so many underage pregnancies? Do they go and check? Are they doing something about it? Are they following up with court processes? What is being done in terms of that? And I would also like to know the Department of Health response to Statistics SA with their numbers, if the department has a response in terms of the statistics we heard today. Thank you, Chair.
Thank you very much. Thank you to the department. Can you please respond?
Thank you very much, Chair. I'll start with the last one and work backwards. In terms of statistics, actually, majority of the statistics that was presented by Status A is actually generated from health. So we actually are aware of that statistic, and we are actually sharing it with other departments to say they need to come to a party. And I also indicated in the beginning of my presentation to say the challenge we're dealing with in sexual and reproductive health is all society approach that we need to do. So some of the issues, although they are being reported in health, actually the interventions are with the sister departments. I'll talk to them as as I respond to some of the questions. Yes, we are aware of the statistics, and we actually have the recent statistics, the updates on that, because most of those data elements are collected through health. So in terms of what are we doing, we've created what we call a youth zone and a BWise. So those are the platforms that we say for young people, speak about it, talk about it. And in the youth zone, we actually allocating them a young healthcare professional who understands their lingo, who understands their behavior, who actually engage with them in terms of their sexual and reproductive health needs, in trying to mitigate some of the issues around the attitude and non-respectful care. So, but I've also spoken about the respectful care approach that we embedded within the one of the quality improvement project. To say we are aware, we are not denying the fact that there are still pockets of non-respectful approach by healthcare workers. So we're working on that. So the BWise is the health technology platform where they can text, they can interact, they get messages, they get understanding of what is pregnancy, how your body develops, and all some of the issues that comes in. So the question around ABC is still there. The challenge we're having is when you look at ABC, we cannot bury our heads and continue to deny the reality and the changes. Issues around abstinence. So if you build that, you also need to bring in to say, in case abstinence didn't work, what do? Then you already build in some preventative measures like the emergency contraceptives. What if it happens without your consent? You still have to do that. So it is still there. If you go to our the latest guideline on HIV, we're still working on it. We also even have we still have Love Life, we still have Soul City that are actually talking about all those messagings. So it's still there. In terms of the people with disabilities, I've noted this request. What we often do is during September is specifically focusing on cervical cancer. And what we do is we have partners, and then we have partners who are actually doing mobile screening for particular cohorts of people. So if there's a possibility of identifying a particular place where there is a need or where you could bring together a quite reasonable number, we have partners who assist us in mobile screening. So they do breast, they do cervix, and then even for the boys, for men, they do PSAs. And now recently, we've built in some other components of sexual and reproductive health. So if that information is available, we can arrange. What we normally do, September is Breast Cancer Awareness Month. We work with different NGOs, the Cancer Alliance, the Pink Drives, and many others, so that we have activations all over the place. As I speak right now, this team is in Northern Cape. So they are actually doing a mass screening. Last month, they were in Mpumalanga. So they move around. So it's just to identify the cohort that we need to focus on, and then we assist with that. In terms of the binding policies, we need to acknowledge that it's multi-sectoral and it's multi-faceted. So we need to, and it has both benefits and disadvantages. Much as I agree that we need to find people and arrest people, but we also need to balance the benefit of saying, if the health, which is the one that is identifying them and assisting them and supporting them through the difficult time of them being pregnant, at the same time if it becomes the same department that implements the punitive measures, we're actually going to send them away from us. So we won't even know that the problem exists. So what we're doing is we're working with sister departments to say somebody must take over. So from school, they have the part on comprehensive sexuality education, which is actually assisting them to identify pregnancy early, to seek help, support, and all that. And then you have health where they access the service. And then we need to pass the baton to other departments, justice, and somebody else who comes into play. And then if you ask me what will be the role of members of parliament, I'll tell you that's where you would cut across to say, when in this continuum, at what point do we hand over the baton? And then the Department of Justice, the Department of Subs, they're the ones who provide that service, so that at least these young people, they've got an area where they would think it's safe. If home is not safe, social development will take care of that. But if school is not safe, the Department of Education will take care of that. But when everything else fails, they'll need to come to help. But when it needs to get to punitive measures, then we need to pass the baton to law enforcing agents. So I think if we all are involved in this, we may start reaping the fruits of all the guidelines that we've put together. And then the issues around what are the actual causes. We know exactly what causes are. We call them 5 H's. It's hypertension. And remember, hypertension is associated with lifestyle. It's a lesson for the whole day if I start talking about it. But actually, it's also talking to a pregnancy-induced hypertension. We know it's hemorrhage, and we know hemorrhage because it's associated with nutrition. If they start the pregnancy with anemia already, by the time they get to delivery, already they are prone to bleeding. Their bleeding is not controlled, and they're likely to complicate from the bleeding. We also know that it's about HIV. While we're saying the resources have been poured on HIV, we still see more than 34% of the maternal deaths are actually associated with HIV-related complications. We're no longer dealing mainly with incidences of diagnosis, but we're dealing with complications where the viral load is not suppressed, or there's the first line or second line drug failure. So there are complex cases that are still contributing to this. But embedded within HIV is also TB. TB is still reality and is one of the contributing causes. So we do know that there are those things, that those are the things that contribute to the maternal death. But the healthcare workers, yes, we know it's about the skill, we know it's about their attitude, and we also know it's about the competency. So that's why we have programs to respond to that. The health system, somebody mentioned a question around the numbers and all that. They've created the whole program that is called Ideal Clinic Realization Program, which is trying to manage those issues of saying numbers, first come, first serve, so many in this day and all that. So the clinics are being evaluated for compliance, they're being given the models, they're rated and all that. So there is the whole program to respond to the health system issues that is talking to that. And then the whole sector approach in terms of awareness of cancer. So we are very open, like I've indicated previously, to say issues around cancer awareness and what we do. They actually, we have dedicated periods. February is the cancer, whole cancer period. September is the cancer month. October is a cancer month. November is a cancer month. Actually, we've got 6 months out of the whole year that are actually dedicated to cancers, different cancers. So actually cancer, there's a lot of work that is happening. Last question is about, do we have enough funding for cancer? No. Let me just be as brief and precise as that. The answer is no. There's still more resources that needs to be mobilized for us to respond to cancer issues. Thank you.
No, thank you. Thank you very much. Honorable members, I think there's a lot that we need to understand as far as this health care is concerned. Is there any other members who like maybe to ask questions?
Chairperson Mantuli, if the presenter can maybe elaborate on the oncology centers in government hospitals as to how they manage that and how is that centralized, and also the waiting periods, because previously that was one of the serious problem for the people with cancer, to wait for quite a long time to get that sorry, the proper treatment. Thank you, Chairperson.
No, thank you very much. Can you respond to that? I think we need some more time.
Yeah, I think that the previous speaker was very faint. I'm not sure if I captured everything. You'll assist me, Chairperson, if I miss some. But I understood the question as saying, I need to elaborate more on the centralization and decentralization of oncology services within the public sector. Did I capture that right?
I think so.
Yes,
okay, thanks. So there are two issues. Cancer, let me talk particularly about cervical cancer. Number one, the first fact about cervical cancer is it is preventable. It's one of the few cancers that is completely preventable. The reason why it's preventable is we know exactly what causes it, which is the human papillomavirus. And that human papillomavirus is transmissible sexually. So it's something that can be prevented. So that's why we have an agenda that we call elimination of cervical cancer. So the focus then is if we have a cancer that is completely preventable, there's no point in centralizing the service at the tertiary institution where we already need oncology. We need to strengthen the prevention component so that it doesn't escalate. But the second fact about the cancer is it's slow growing. So the return in investment of the program that we're implementing now, which is vaccination, it will take about 10 to 20 years before we see the impact. For an example, our program is only 9 years old, and we were giving it to 9-year-olds. So if you add up, they are only 18, and the screening starts at 30. So we still have to wait 10 more years before we see the impact of the investment that we are doing now. So yes, we know there was a cry, the issues around access, but in terms of preventative components, it takes a long time before we see the benefits of the programs that we are implementing. The third fact about the cervical cancer is it has got what we call a cancerous period. So pre-cancerous period, it means you have a problem, but it's not yet cancer. So if it's not cancer, it doesn't require oncologists. It doesn't require sophisticated machines. It doesn't require radiation. It doesn't require chemotherapy. And it is at that point where we say you don't need to go to specialized hospital. That's where we say at the district hospital, all you need is your gynae person or a trained physician or a trained family physician. They can still manage that precancerous lesions. That's where it's on its way there. So when we say we decentralize and we say, let's catch it at the preventative era, let's also catch it at the precancerous lesion so that we reduce the number of patients who end up with the full-blown cancer. And when we get to cancer also, it's staged. So in regional hospitals, they can still manage the first and the second stage of cancer because the management at that point is surgery. So surgery can be done in any regional hospital. So you don't have to wait until you go to oncology. But when it gets complicated, it gets to stage 3 or 2B or 4, that's when you would need very expensive, very radical, highly sophisticated specialists and equipment for it to be managed. So when we say we're decentralizing, we say at any point of level of care, we need to do something about cancer so that we don't have a situation that we had in 2018 where we had a backlog of a lot of patients waiting for that. But also, it's got the post-treatment component, which is palliative care. So there are cancers where it's at a stage where you now need to refer back to the palliative care, where it's about comfort, reducing pain, comfort, and how to manage the disease and to minimize the complications and the spread to other organs and to still be functional. So that component also, it does not require a tertiary service. So that's where the NGOs comes in, that's where partners come in, that's where the alliances come in, where we refer them to say, let's make sure that the people who are living with this at this stage, they get enough palliative care because then they should remain functional up until the end of life. I hope I've answered the question clearly now. Thanks.
Thank you very much. Thank you very much. If there are other questions, honorable members, I think we can do or indicate by writing. Then we'll also talk to the secretariat. If there is a need to call them again to come and present, we'll do so. But for now, honorable members, it's 25 minutes past 1. And when you check, we started being 50-something. Now we're at 36, meaning members are leaving one by one. The minutes of the 15th of June. But I just feel that we need to defer the minutes to the 16th of, to the 21st of September for adoption, in order for now to close the meeting, Gauteng and around there to go and do the work that they are supposed to do. And thank you very much to the Department of Health, Department of Women, Youth and Persons with Disability, the state's presentation. Thank you very much, honorable members, for attending your caucus. The then adjourn.
Amandla Chairperson, malibongwe.
Kamala makhosikazi.
Thank you.
Ma